Good afternoon from the PQA studios in Alexandria, Virginia, and welcome to the 2021 PQA Annual Meeting. I am Lauren Kirk, PQA Senior Director of Strategic Partnerships, and I think I know what you're thinking. Not another online meeting. So, rest assured, this is not just another online meeting. We have preserved the elements that make this meeting uniquely a PQA Annual Meeting. It includes 36 educational sessions addressing top issues and emerging trends in medication quality, measure development and implementation, and care transformation and technology. In our general sessions tomorrow and Thursday, PQA will host a collection of experts to speak to equity in medication use quality, COVID-19's impact on quality, and real-world examples of value-based care. This year's focus sessions will deliver timely and actionable information in 30 minutes. They feature a variety of topics including value-based care, social determinants of health, COVID-19, and patient engagement, all presented by PQA's diverse member organizations. On Monday, we will share more about PQA's work in medication access and social determinants of health, and showcase more than 20 research posters on a wide array of topics related to medication use quality. And of course, it wouldn't be a PQA meeting without networking and connecting. You as attendees will have the opportunity to network with the PQA board and staff members, test your trivia knowledge against fellow attendees, and attend collaboration sessions and office hours with PQA's performance measurement team. Today, though, you'll hear from PQA's CEO Micah Cost. He'll share his insights on the first 100 days leading PQA and his vision for the future. You'll then hear from 4 leading vendors with creative business solutions during the Innovation Theaters, featuring AspenRx Health, Enliven Health, Outcomes MTM, and Tabula Rasa Healthcare. And finally, we'll round out the day with our trivia hour. None of this program would be possible without the support of our partners in quality. And we thank our sponsors and supporters that help make the PQA Annual Meeting possible. These organizations are leaders in quality and committed to supporting programs and initiatives aligned with PQA's mission. You'll be hearing more about them and from them throughout our meeting. Thank you for your sponsorship and support. I encourage you as attendees to visit our sponsors through the Sponsors tab. Each of our sponsors has an individual profile where you can learn more about their innovations, schedule and join instant virtual meetings, and send messages to connect. In order to join us today, you had to log in through an online meeting platform that had so many functionalities that will facilitate and enhance your meeting experience. I have 3 recommendations, though, of how you can maximize your meeting experience. The first, log into this meeting platform on 2 devices. Use one device to attend sessions and ask questions of our speakers. Use the other device to engage with your fellow meeting attendees and sponsors throughout the meeting. Second recommendation, build your meeting schedule through the All Sessions tab. Save your sessions to either your meeting schedule or your personal Outlook calendar. You'll be able to move between sessions from room to room just as you would at a live PQA meeting. And I suppose you could cherry pick sessions, go from here to there between your lunch break and another call. But the schedule for this online meeting is designed to provide you with a complete experience. And finally, and third there, connect with your friends and colleagues through the Attendees tab. You'll be able to visit their profiles and schedule an appointment to chat with them during or after the meeting. And while we understand the time between sessions would be perfect to rehydrate, use the restroom, and of course make sure the kids are still in the Zoom classroom, I encourage you to run into your colleagues in the hall and meet new connections at the virtual receptions bar. 2 final notes, though, before we really get started. If you encounter any connectivity issues or technical difficulties, please contact us at registration@pqaalliance.org or visit the virtual help desk session. And finally, take part in the conversation by using the hashtag PQA21. So, with everyone settled and all of that out of the way, let's get started. Micah Cost is PQA's Chief Executive Officer, and he is on his 99th day with PQA. He joins us here at the start of the PQA annual meeting to welcome us and share his vision for the future. So, without further ado, Micah, please take us into the 2021 PQA annual meeting.
Thank you, Lauren. Welcome to the PQA annual meeting. I'm Micah Cost. The Pharmacy Quality Alliance recently turned 15 years old. And with this comes a great opportunity to reflect on the bold vision that established PQA, a roadmap of our first 15 years of success, and where PQA and medication use quality are headed in the future. I'm excited to be joined this afternoon by Mark McClellan, who's the founding director of the Duke Margolis Center for Health Policy, and Larry Kocot, who is a principal at KPMG and national leader of the Center for Healthcare Regulatory Insight. Back in 2006, Mark was the CMS Administrator and Larry was a senior advisor. And these two individuals were instrumental in PQA's creation. When they established PQA, Mark said, "The launch of PQA is an important step toward a pharmacy business model that reports real value delivered rather than just the volume of prescriptions dispensed." It was a visionary declaration recognizing the direct influence of medication optimization on value-based care. So Mark and Larry, welcome. Question number one, Mark, we'll start with you first. The Medicare Part D program has just been established. Can you share your reflections on the goal you had for PQA in driving quality in medication use?
Micah, first off, it's great to be here with you and great to be back with PQA. Congratulations on 15 years of making a difference. It was a real privilege for me, I know for Larry as well, to be part of the beginning of this enterprise. And to your question, when we were starting Part D, we knew that this was about more than just providing a drug benefit. That was challenging in itself in setting up a drug insurance program for seniors, for people with a disability who'd never had this kind of systematic drug coverage before. So there are a lot of questions about just how well that would work. But it was also really a new enterprise for CMS and the Medicare program in a couple of other dimensions. First, we needed to get expert fast on what was important in managing a drug benefit, and that meant getting expertise in pharmacy into the agency. When the bill was passed, I don't think there were any pharmacists on staff at CMS. That's why Larry Kocot was one of my first hires to bring on board to help with so many aspects of implementation of this program, but most importantly for his deep connections and expertise in the pharmacy space and working with pharmacists all over the country. The second thing was we knew we didn't want to do this sort of the same old way. And by the same old way, just fee for service, focusing on delivering, checking a box, delivering a service, delivering a prescription, but really making care about people. And there were several parts of the Medicare Modernization Act that helped make that happen. One was some authorities that were the forerunner of the Center for Medicare and Medicaid Innovation, some additional ability for us to try out new models of care. Second was the implementation of the Medicare Advantage program, which provided a new kind of private sector avenue for comprehensive access to medical services, including prescription drugs. And third, of course, really most visibly and obviously critical is the drug benefit itself. But we wanted to do the drug benefit in a way that would make it more about people. And that's where the PQA really came in. It was clear at the time that there was so much work that needed to be done around understanding the quality of pharmacy services, around supporting access to quality services so that the drug benefit could be delivered effectively. And it was just a great privilege to work with Larry and to work with Laura Cranston, with so many pharmacists around the country to stand up that enterprise.
Absolutely, an innovative dream that has come together to reality. And so certainly appreciate your vision. Larry, much of that vision for PQA was based on the belief that pharmacists had a major untapped role to play in delivering value-based care. How does pharmacy quality improvement empower pharmacists and also benefit the broader healthcare system?
Well, first, Mike, let me also congratulate you on 15 years of PQA. This is really wonderful to be back here. It's such a delight to be with Mark. Like he said, it was a tremendously difficult undertaking, but there were a lot of rewards to it. One of the big rewards that I know that I had personally was the creation of PQA and watching that launch. I have to take you back to 2006, though, because when we started this pharmacy benefit, There was a lot of success, but there were a lot of disappointments, frankly. When we started, pharmacists weren't exactly happy with where they were with plan reimbursements. MTM, remember, was the promise for pharmacy's future, and it didn't really turn out to be as much as what pharmacists really thought it was going to be. The pharmacists did have it wasn't all roses, to be honest with you. There was a lot more expectation of being compensated for the value that they delivered. Mark and I recognized that value for what it was, but the problem that we couldn't get over, and what we tried to emphasize to the pharmacy community continually, is we really have to demonstrate that value. We have to be able to measure it in order to quantify it and get you paid for it. And that really was the impetus for the conversation that started the PQA. I talk about where we come from in 2006, where we've been and how far we've come is just amazing. You've developed a community and a set of adherence measures that are really a foundation to build upon for the future. And how far we have to go is the next challenge, which I'm sure we're going to be talking about further in this conversation. I'll hold on that for a little bit later. But again, I want to thank you for having us back here. It's such a pleasure to reflect on this success that you've had, and to be part of it was really a highlight of my career.
Absolutely. And certainly appreciate your perspective, and excited to dive a little bit deeper into those discussions as we go along. As we know, PQA's foundational quality measures deliver value and focus on health plan claims data. The evolution of pharmacy practice and the pharmacy system data is ushering in really an exciting new era. What do you see as the most promising areas for pharmacist provided care that can be tracked, measured, and rewarded? And I guess we'll start with Larry and then move to Mark.
Yeah, I think as we look to the future, Micah, we look to the past, adherence measures are something that pharmacists can certainly contribute to and should be compensated for if they provide value. Really, for the future, the same things really hold true, is pharmacists must be able to impact those measures, and we have to find a way for pharmacists to get paid for the value they deliver. Those are not really easy challenges to meet, because you're almost putting the proposition out there ahead of time, and you have to convince the plan that's the way that we should take this. But there's been a lot of models out there that have a lot of good measures. There's certainly the roadmap for HIT integration that has a number of measures that leveraging pharmacist-patient relationship to optimize medication therapy, better resolve polypharmacy, assess and collect patient data, reported outcome and social determinant of health data, incorporating pharmacist care plans into interoperable workflows, et cetera. There's a lot of things that pharmacists can do that provide a lot of value to the overall benefit, that really probably are the first steps to the building blocks of what comes next. And that what comes next is really going to be up to you and this group that you've assembled and you've taken on to be a little bit creative. I really challenge PQA to really, in the pharmacy community, is to really get out of your comfort zone. The problem with where you sit and where you go from here is consensus-based organizations tend to go to the lowest common denominator. You have to get agreement among everybody. I think you really have to focus on stretching beyond the comfort zone of some of the lowest common denominator to get to that next level. And that's going to be not only, it's going to be very rewarding to get there, but it's also going to be a challenge to take that step.
Yeah, I would just to add to that, I think some of the core measurement and quality improvement focus areas that PQA has had are still relevant. And what still matters is, are patients on the right medications? Are they having their medications managed effectively to understand them? Are they adhering effectively? And most importantly, do they get the best outcomes at the lowest cost? What I think is changing is the opportunities that pharmacy has to influence those results as a result of increasing access to data and increasing digitization of healthcare in terms of new sources of data. Hopefully there can be more opportunities for collaborating with health plans, with medical practice groups that are accountable for the results for a population of patients, to share additional sources of data on when there might be opportunities for interventions. We know a lot more about the factors from claims and many other sources that influence whether a patient is likely to adhere and whether a patient's likely to have a bad outcome on a particular medication and think about what's ahead, everything from richer big data sources to genomics, that's going to get more sophisticated, and pharmacists should be a key part of that. And we're also seeing care move out of the office and further towards and into the home. And that doesn't mean pharmacists aren't going to be part of that. It just means that if we think about telehealth, it's not just a connection to a doctor on video. It's really a whole set of virtual services from a team of providers that enables better outcomes at home, especially for the growing number of patients who are going to be on costly but potentially really important medication therapies, with all the immune treatments being developed, all the additional cellular therapies under development, and a whole range of medications coming down the pike, everything from significant opportunities for weight loss to maybe early stage Alzheimer's management. So some unprecedented opportunities for patient management, but I think increasingly shifting to the home and increasingly viewing pharmacists as a key part of a technology-enabled and virtually augmented care team.
Certainly one of those areas that would seem to drive a lot of that discussion would be social determinants of health and health equity. I think we're seeing that play out in real time right now, and it's certainly one of our focuses here at PQA, but it plays a particularly important role in medication use quality. And so I think as we drive toward that better value proposition for our healthcare system, it's going to make a big difference.
That's right. Just a comment on that. A lot of the focus areas around social drivers that we're seeing now, most state Medicaid plans focusing on, Medicare beginning to focus on as well as a high priority for the new CMS leadership, include areas like food insecurity, adequate access to housing, other areas that just get in the way of people being able to focus on their medications, even if they have a prescription and have good coverage for it. As we're seeing more data systems and more supports build out around connecting people to supports that can address those issues, I see pharmacists being quite important as like that frontline healthcare provider can potentially help with addressing those social drivers of poor health and that have so much of an impact on being able to afford and use medications effectively.
Mike, it occurs to me that none of this is new. Pharmacists have been doing this for centuries, for at least a century, in determining what the patient, where is the patient really at in terms of what their needs are. Not uncommon for the patient to come in and tell the pharmacist things that they would never tell a doctor. The pharmacist comes in and goes on about their lifestyle and about their issues that they would never get in a conversation with a physician. So taking that and somehow getting, as Mark says, getting it into the data to make the data real is a challenge, but it's really something the pharmacists have been doing for many years. And we just have to figure out a better way to capture that as part of that patient experience.
And just not just keep going, but Larry and I could go on all day, but in thinking about further areas for measure development, measure engagement for PQA, I think about somewhere, the social drivers clearly matter. One that's really front of mind right now involves vaccination, where pharmacists are now right out there. They're trusted in communities. They're the place that's easiest to access, especially for people in underserved communities. We're leveling off on our use of vaccinations now, even though if you look at the surveys, there's still a lot of people, especially from Black and Brown communities, especially from lower socioeconomic groups, more rural areas, who at least want to find out more about vaccinations, if not get them. And pharmacists are going to be a critical part of access to that. So you're thinking about for measures like vaccination, which I think are going to be part of the CMS agenda for the next year or two, are there ways for pharmacists to be a big part of that?
We could go on forever. Mark and I are working together on a number of different things, including monoclonal antibodies. And eventually we're going to get to subcutaneous and oral therapies for things like COVID-19 and other pandemics. And obviously pharmacy is at the core of that. It starts with that continuum of where we've come in this pandemic, but the pharmacist is going to end up doing this on an everyday basis. So we need to be prepared for that. And Mike, I know that the PQA is very well equipped with you at the helm to look forward to how we go into this next phase of this pandemic and then beyond.
Well, so I can do this to a little bit of a discussion on kind of the future for standardized pharmacy measures. And so in response to the pharmacy stakeholders and some of the industry perspectives, Congress and the administration have made hints toward standardized pharmacy measures. And so PQA is responding to that by developing those standardized sets. In terms of measurement, they're only effective if they're implemented within the marketplace. And from y'all's perspective, what do payers need to see to further elevate pharmacy in those value-based agreements and to more wholly integrate medication services into team-based care? And we'll start with Mark and then move to Larry.
I think, Michael, we've already touched on this. I think it makes good strategic sense for PQA to be focusing on this area. I would emphasize not just developing the measures, but making sure, as you have tried to do over these past 15 years, to link it to a strong evidence base that improvement on the measures gets to those bottom line outcome impacts, improved health outcomes, avoiding costly complications or inappropriate medication use that are so important to getting value in our healthcare system. And looking ahead, as I mentioned before, medications are going to get more complex, not less. Data is going to get more sophisticated for not only identifying which patients are actually likely to benefit from a particular medication treatment or have a complication, but also what tools and supports and interventions are going to be most helpful in making that happen. So making sure you're part of generating that data and acting on it is critical. I do see, in terms of payments, a continuing shift away from maybe fee-for-service payments for specific services and towards more payments for teams. If you think about the flexibilities that made a lot of difference in the pandemic, telehealth was one, site of service flexibility was another, but under the alternative payment models that existed before, and I think are going to be reinforced coming out of this pandemic, those payments can go to teams. There's a lot more flexibility when you're moving away from fee-for-service for an up-to-date role for pharmacists than if we just focus only on trying to make a incremental push or shift in Medicare fee-for-service payment schedules. So really think about building out those teams, which is definitely right in line, I think, with the future of healthcare delivery, more advanced and sophisticated and personalized medication use.
I have to agree, not surprisingly, with Mark in terms of that team-based care and frankly, moving away from fee-for-service into a value-based context. It's disappointing that you are where you are in terms of developing that measure set because of penalties that pharmacies have been imposed on pharmacies for things that allegedly you didn't do, but you didn't know what they were. So it caused CMS to say, you have to report this in order for it to be transparent. Also, legislation like HR 3 codifies that and requires a consensus-based measure set in order to reward and to penalize pharmacists. But I think getting away from the penalties, really you want to focus on the rewards first. The penalties are fine if you don't do what you say you're going to do, but you can't be held responsible for something you didn't commit to. And that's why that team-based care, moving away from fee-for-service and getting to that value-based care where you are making commitments and you are being held responsible for them, penalties or, frankly, rewards. The rewards should be there just as much as the penalties. It shouldn't start the other way around. So getting away from fee-for-service, I think, is going to get you there. And I would encourage pharmacy to jump on that bandwagon. Mark leads so well with the work that he does with the land and other things, and we'll continue to push in that direction because pharmacy, that's a key part of pharmacy's future.
One of the obvious strengths of PQA, I think, is its ability to bring together stakeholders from a variety of different viewpoints and backgrounds to really focus on how we standardize a measure set. And I actually see that as one of PQA's greatest strengths is bringing everybody together to come up with that consensus perspective. And when we talk about standardized set of pharmacy measures, PQA is really optimally positioned to do that. And I think we do have an opportunity here to be bold a bit. To Larry, to your point about being bold about our goals, I think we have an opportunity to really stretch that opportunity in order to make sure that we reach the largest number of patients possible. And I think that's the future for PQA. And I think that's a huge opportunity for us to jump into the water and figure this stuff out as we go. So it's a brave new world.
Yeah, I wish all this was easier, Micah, but I also really appreciate all that America's pharmacists are doing to help us get to that better healthcare delivery system. Boy, we've seen we need in the pandemic, if we had any doubts, really seen how critical pharmacists are.
So this is a big picture question. So we're now 15 years into PQA's work to improve medication use quality. What do you predict for the future? Where will performance measurement and quality improvement have the biggest impact on the use of medications in the coming years? And Larry, I'll start with you on that one.
I've never been a big fan of predictions because I'm usually wrong. But in this case, the future is really dependent on a variety of different factors, including leadership. And I have no doubt performance measurement is going to get better, and it's going to be more refined in impacting quality improvement. And pharmacists can be a part of that. But strong leadership is going to be required to drive consensus beyond, as I said, that lowest common denominator. And pharmacists are going to have to continually be pushed to get where the rest of the healthcare system is going. That opportunity to be a provider has to be more important than just being called a provider for pharmacists. You have to jump in, as Mark said, with team-based care, with value-based care, and really do what pharmacists have been trained to do. And frankly, we got to figure out a way to have pharmacists compensated for it too, because you can't do it for free. So many times pharmacists have jumped in and said, if we do this, then the payment will come. That hasn't happened. So the measurement is there to improve the quality, but it's going to take the leadership to be continually recognized and financially rewarded for the contributions the pharmacists can make to those better healthcare outcomes. And we just have to keep pushing for that, Micah, because it will be there in a value-based care regime and a team-based care arrangement, but it's not going to be there if the pharmacist is there just filling pills and billing for a prescription.
We are seeing, just to briefly add on to that, more efforts to get to consensus aligned measures in other areas of care, primary care, specialty care, et cetera. And it's a critical role for PQA to bring the pharmacy sector together in that same direction. And along with that, again, just growing interest in demonstrating that these quality improvement measures do really lead to better outcomes, to lower costs and improved data systems, and PQA's ability to collaborate with data experts, other parts of the healthcare system can advance that work. And I do think you've got, if you embrace this, the future's with you. People want care that's more convenient. There's going to be better ways for pharmacists to work with clinicians, with other parts of the care team more easily using digital technologies and AI and other tools. So we can get there. And I think it's a really special time for PQA to help show the way.
So 15 years down the road, we're all live. And we're sitting on a stage together and we're reminiscing on the previous 15 years of PQA and the 30-year existence, and our healthcare system's optimized. What does that look like? And we'll start with Larry on that.
Again, I think pharmacists not only being on the team, but leading the team in some respects. This whole push to consumerism, Micah, that is totally within the wheelhouse of pharmacists. The consumer knows the pharmacist. The consumer goes on the journey with the pharmacist more often than any other healthcare provider. And if the pharmacist is going to be there in 30 years, the pharmacist has to be leading and really stretching beyond it. I realize there's Practice Act and there's license issues and everything else, but increasingly, the pharmacist is being identified with so many different services that the pharmacist can provide better than any other healthcare provider. Just got to keep pushing for that. Stretch to the top of the license and keep moving forward.
If we really have achieved all of that, I'm going to be doing that conference by video from a beach somewhere, so I'll be retired. But in all seriousness, there is so much potential here for the future of pharmacy, the future of healthcare. As Larry said, it's more about consumers and directly interacting with consumers to stay well, backed up by a lot of expertise and technology, more medications, more diagnostics that are going to be able to work to keep people well, to keep them out of not just a hospital, but any traditional healthcare institution, much closer to home. And really looking forward to seeing PQA's role after 15 more years after what you've accomplished so far. I have really high expectations.
We really appreciate the conversation this afternoon. Larry, Mark, it was a pleasure to have you. Your visionary stalwarts and your efforts to get PQA off the ground are certainly well appreciated. And we're grateful for the leadership and the vision that you showed in getting this organization going. We're looking forward to a promising future for PQA. Now we'd like to take the opportunity to open up the floor for questions from the audience. And so Larry and Mark, we're going to have our questions fed in, and we'll take those questions now.
Well, thank you all for participating. Larry, it's great to see you. Mark will be joining us soon. It's a pleasure to be able to address you and to have that rich conversation, Larry. So I'd love to jump into a couple of questions. I'm gonna ask you one of the questions that's kind of top of mind for a lot of pharmacists. The fight for provider status will continue for a while. What should pharmacists focus today, independent of provider status, in terms of delivering services and care for patients that improve outcomes and contribute to value-based care?
Mike, I'm gonna talk a little bit. First of all, I've never been a big believer in provider status as the answer to.
Okay, hang on. I'm going to hop into. Oh, no, I can't. Morgan, can you go to VCAM 2?
Can you hear me, Micah?
We can hear you, Larry.
Should I continue?
Absolutely.
Okay, I apologize. As I started to say, I've never been a real big believer in provider status as the answer to demonstrating pharmacist value. Rather, it's a statutory path to greater reimbursement, but that doesn't mean that there'll be greater value added to patient care. I think that really depends on what the pharmacist does with that provider status, assuming that does come. But in the interim, there's a lot the pharmacist can do and a lot the pharmacist should be doing. I want to go back to something you said before I go there, though, and talk a little bit about Medicare and Medicaid programs as a starting point, particularly with regard to this standard pharmacy performance measures. In the context of these programs, dispensing fees include only routine costs of dispensing drugs, right? So drug costs don't include quality improvement payments. So as a result, quality withholds and incentive payments taken from or included in the drug costs are potentially problematic. So I would encourage people to think a little bit beyond that, because in order to get to where you want to go, separate payment streams are needed for appropriate reimbursement to do outreach and engagement activities that are not part of dispensing. So you need to go beyond those performance measures and figure out, if you are adding performance measures, there has to be payment along with them. It can't be part of that dispensing fee. So what can the pharmacist do, and what performance measures should you be looking at? In my opinion, it's focusing on those higher value populations, the higher risk populations, I should say. That must be the denominator. In other words, you need to be looking at those patients and what you're doing for those patients, as opposed to the overall population of dispensing patients that you're working with. They're really going to yield that return on investment, and I really do think that that's where the value is. The higher risk populations, are going to be defined through comorbidities that pharmacists could observe through prescribing drug therapies, through addresses in neighborhoods, for example, when we talk about social determinants of health. But to be truly successful, pharmacists they need access to more data to identify populations that they're going to be accountable for in terms of performance. Pharmacists can't be dependent upon other parties for sharing information to identify the target populations when they're held accountable for performance if they don't have that data themselves. So there are a lot of services that pharmacists could take on today. In fact, some pharmacists are. Pharmacists can observe abandoned prescriptions and identify selected drug classes, conduct outreach independently, following up for patients for primary non-adherence, something pharmacists do very well, but now electronically prescribed high-value drug therapies, very valuable services for plans. Pharmacists can administer screening tools, conduct education and counseling with customers, screening for untreated and undertreated conditions, for example, assessing history and conducting counseling, screening for vaccination for prevalent infectious diseases, for example, COVID-19, Hep C, influenza. There's a number of different services that the pharmacist can provide that certainly provide a lot of value to the plan, a lot of value to customers that could be paid for. And then there's obviously the medication regimens in conducting MTM directly with customers, medication problem resolution, and in the future, smart dispensing devices and so forth. Pharmacists will definitely have a role in playing more in monitoring and accurately managing adherence. But again, we go back to what's the motivation for doing this? Are pharmacists going to get paid for it? And that we seem to be always coming back to that. Are pharmacists going to get paid for it? And that goes to the value. If the value's there, the plan will pay for it. Anyway, let me pause there, Michael. Let's go to another question.
Sure, and this kind of follows on to the comments you just made around data. So we know that there's a rich amount of information that's being captured outside of the traditional data sources, and so pharmacists really have a good opportunity there to close some gaps in care. So what's needed in your mind to close those gaps and incorporate some of that pharmacy-specific data into the larger data set?
Well, it's one thing that's frustrating for pharmacists, I know, and for the standards organizations that pharmacists are part of, is the standards do exist. There just isn't enough interest or value in setting up the data feeds for pharmacists to access a lot of that information. There has to be an ROI to the services that pharmacists are providing in order to track the investment in the pharmacy services, and pharmacists need to be pharmacists need to be part of that ROI in order to get that investment. One thing that's very disappointing to me is the recent MTM demonstration on for enhanced MTM. It's disappointing because the evaluators included the cost of the plan incentives to determine the success of that demonstration. The demonstration really wasn't about how much to pay the plan to incentivize better care in Part D. The demonstration was supposed to be about the value of the interventions. And I believe that if pharmacists look closely, there's a rich data set there for pharmacists to harvest to take, to take away the cost of the plan. If you take away the cost of the plan incentives in doing the calculation and the evaluation, the demonstration was a huge success in terms of the ROI that the pharmacist could provide. And if you look closely at that, I think you'll see a lot more there. That leads me to a policy suggestion. When we established, and I'd like to get Mark's thoughts on this, we established the MTM program in 2006. We really had no experience with the drug benefit. Drug costs were much lower. The mix of drugs was not heavily weighted to generics. It was a lot, what I should have said, the mix of drugs was not as heavily weighted to generics at the time, and the costs were not driven by specialty drugs the way that they are today. It's really time, I think, to rethink that MTM program in terms of what the pharmacist can do to improve the quality of healthcare, specifically in the Medicare Part D population. This would be consistent with other changes that are being contemplated in H.R. 3 and other legislation currently before Congress, and will become even more prominently looked at by Congress as we go on in the year. Given our experience with Medicare, MTM, Medicare Part D and MTM, it's time to unlock that potential for pharmacists Part D. And a couple of things I would suggest is we start by looking at the highest risk patients in terms of the health trajectory they're on, rather than just the chronic diseases they may have. In other words, we can see a lot more coming for those patients that the pharmacist could intervene in and frankly show a lot of value in. We should also be examining or re-examining the cost thresholds for requiring MTM for Medicare Part D beneficiary. Those are a lot different than they were in 2006. And frankly, the evaluation of what the costs are in terms of the drug costs and really what we could be doing for patients based on their cost is something that should be reevaluated. And then finally, after requiring just a reflexive check-the-box exercise of medication reviews in the current MTM programs, we really should think about requiring plans to meet real quality measures and be held accountable for the results of their MTM programs, rather than just having an MTM program that they have to show as part of their plan. That would be, to me, a good starting point for looking at pharmacists and Medicare Part D, and really, is there a path forward to better integrate the pharmacist into the Medicare Part D program to show real outcomes for patients?
Well, welcome, Mark. Larry referenced you. I wondered if you had any thoughts to add to what Larry just described.
Just to pick up on the point about the opportunities for pharmacists to play a bigger role as drug spending, especially specialized drug spending, continues to increase. I completely agree that the focus ought to be on demonstrating value add. And I think some of the PQA measures are a basis for that, even if the reimbursement systems don't pick that up directly, don't directly pay for MTM results. That's something we could be aiming for. But it is something that organizations that are increasingly held accountable for getting better outcomes at a lower cost can do, just as we talked about earlier in the earlier part of this session. And I hope there's some opportunities for progress there. The challenge with Medicare Part B is, as Larry said, right now reimbursing kind of entirely on a fee-for-service basis, which is a markup for the clinical entity that delivers the drug, and not really any direct connections to quality or value. We've seen that start to change outside of the Medicare market, traditional Medicare market, Medicare Advantage, and some commercial plans. They're building out kind of specialized pharmacy services that many of your members are involved in around those costly drugs to really focus on the patient. You make sure that the right patient's getting the treatment's being adhered to effectively. It's been given a setting where the skills for managing side effects or complications are really high, and hopefully often at home. So lots of opportunities there, but it is going to take some further shifts, not just I think towards trying to pay more directly for MTM measures, but shifts towards accountability for the total costs and results for these patients, the growing share of patients who can benefit from specialized drugs and who can benefit from complex, who have complex problems and can benefit from that kind of pharmacist assistance.
Well, so a little bit to that end of value-based care design, a question came in, and it's Mark, specifically in your discussions earlier, you mentioned the role of value-based care and pharmacists in it, and then also the importance of carrying that forward to medical practices. So what type of message do pharmacists need to carry forward to medical groups and medical colleagues around the value they can add to the medication use system?
I think that they can make clear that they're part of the solution, and the PQA measures and efforts very much help with that. We're headed in many of these payment reforms towards models that are more about supporting teams around particular patients and their overall needs, more so than delivering specific services, whether it's an office visit or a procedure or a prescribed drug. It's putting it all together in the context of that patient. So for that patient, what's getting in the way of adherence? As Larry was saying earlier, how can you combine the integration of a pharmacist on a care team with data and analytics that help you figure out the best place and the best way to use those specialized pharmacist services. And I think there are a number of examples of these kinds of programs now. And my hope is that the PQA measurement efforts will increasingly make it clear how pharmacists can be part of effective teams that can deliver better outcomes for specialized patient groups at a lower total cost of care, especially as we're moving more into, as we talked about earlier, home-based care, virtual care models where the traditional physician visit and physician-only approach to care is not what we're going to be doing.
So from Larry, from your perspective to what Mark just described, one of the questions that came in is, are you aware of any examples and what kind of models are out there to address the attribution of outcomes to adequately compensate members on those teams, especially if some of those members aren't a part of an integrated health system? So if you're working across sectors and across populations and in I would say affiliated health networks, but not actually integrated health networks, what type of models are out there, and are you aware of any that you might put up as best practices?
Well, attribution has always been an issue with pharmacists as part of a team, but the outcomes for pharmacists and for all healthcare providers on team-based care, as Mark was saying, should be accrued to the team. It's the pharmacist is part of that team is going to see the attribution of the health outcome just as the team will. And the pharmacist leading that team or playing a leading role in that team, it should be recognized in terms of the value that they bring to the team. I'm not sure I'm answering your question, Mike, about the attribution. I wanted to make sure I understood what you were saying.
No, I think there's a lot of opportunity, and I think from what Mark was describing and what you're describing, the opportunity is right, but we have to use quality to drive that forward. And I think that kind of alludes to the fact that there's an opportunity there, but we're just not quite there for attribution, but maybe it's a direction we need to head in. Question for Mark. One of our audience members has observed some non-Medicare quality programs minimizing adherence as an outcome of interest, categorizing it mainly as a process-based measure. How can learnings from Part D, where we've seen adherence measures be successful in moving that needle, how can learnings from Part D best be shared with other agencies to demonstrate the value of pharmacy?
That's a great question, and I think it fits with, maybe I can also spend a minute, and I apologize, I have to leave a little bit before the scheduled end of this session for actually an urgent CMS issue. I think we can hopefully learn from that Part D experience. The reason that those adherence measures have gotten attention is because there was clear evidence linking them to improvements in outcomes for the underlying condition. So that's the principle that needs to be followed. And you're right that CMS is continuing to push in terms of its overall models for care reform away from specific intermediate steps and towards attention to outcomes. And I would expect to see, and you've already seen it in the priorities for that OMB is emphasized in the new administration, and the Center for Clinical Standards and Quality that oversees the CMS measurement strategy. They've emphasized trying to get to the capacity to use systems of measures as healthcare organizations get more sophisticated at putting data together, including data on medication adherence, but also data on which patients are effectively targeted for certain kinds of especially expensive medication use, and ties to outcomes, including costly complications as well as functional outcomes. That's where CMS is headed. I would add to that increasing attention, I think you're going to see in the weeks ahead towards measuring these outcomes, not just for overall populations, but especially in subgroups of the population where we've seen disparities in health outcomes. So racial and ethnic minorities, groups from vulnerable neighborhoods based on socioeconomic status and other factors. And adherence in those contexts is particularly challenging and important. So less about the overall adherence numbers and more about how do these patient populations do. Now, the adherence measures are obviously a contributor to that, but it's also important to put those measures in the context of actually demonstrating evidence that adherence is a piece of an important piece of getting better outcomes for those population groups. So again, that's back to my earlier point about linking the pharmacist efforts around adherence to pharmacist potential contributions around the overall effective use of medications for the patients who can benefit the most.
Larry, any additional thoughts?
Yeah, I'll just to echo what Mark says. OMB just put out a call for advice on how to improve health equity, and Pharmacist is incredibly well positioned to contribute to that dialogue in terms of not only measures but areas where we can improve health equity directly with patients, given the pharmacist sees the patient all the time, sees his record, sees his or her record, and frankly can see where there's opportunities to give more equal treatment in healthcare to all patients.
Yeah. I just would add that, because pharmacists have so much more interaction with patients than, say, a clinician does, there's a lot of potential here. You're seeing that happen now in the growth of clinics at pharmacies and the like around the country, other kinds of outpatient services, the team-based models that I mentioned before. So hopefully measures that pick up on, that extend the adherence approach to this changing approach to team-based and community-based delivery of care, particularly for patients with complex needs. Hopefully we can see more progress there.
Yeah. Well, absolutely, and that's what we're hoping to lead here at PQA, and excited for the future. Mark, I know you have to jump off. I did want to say thank you for joining us this afternoon. Larry and I will carry on the conversation and solve all of healthcare's problems, and we'll let you know about it in the next 10 minutes.
Well, I hope that's the case, but as always, feel free to call on me anytime you think I can help. I truly have believed in the mission of PQA along with Larry since those early days, and look forward to what's ahead for this organization, with pharmacy becoming yet more important in the delivery of high value and equitable care.
Well, thanks, Mark. Thanks for joining us. And Larry, I've got another question for you. When we look at future performance measures and what they may look like, how can they be developed with a greater focus on outcomes and high quality clinical services compared to product focused measures?
Well, I think we need to look, I want to go back to something that we talked about first before I go to the measures and based on services, Micah. You look back just in the recent history in the pandemic, the pharmacists were called upon, the pharmacy community was called upon to vaccinate. We had a problem. We've got 40% of people who die in this country from COVID were in nursing homes. And pharmacists immediately jumped in across the country, principally a couple of pharmacy chains, but across the country, there's other examples in like West Virginia. Very, very quickly went out to a rural community, used all of community pharmacy, including independent pharmacies as well as chains, and reduced the incidence of death to less than 10% in nursing homes. A remarkable achievement in terms of outcomes. You look at what an outcome is. The pharmacist was called upon, the pharmacist delivered. Regardless of whether one chain, two chains, five chains, or independents, it was the pharmacist community that was called upon. So, in terms of performance measures, I think it all depends on the service that the pharmacist is going to take on. The service will determine really what the measures are and how you develop the measures. So I think it has to be service-based, if I'm answering your question correctly. I'm sorry, I was just thinking about how the pharmacist jumped in recently, and it's been remarkable to watch over the last several months. We're looking down the road in terms, as mentioned earlier, on monoclonals, and pharmacists are going to play a major role as we go forward in containing the pandemic. So we've got a lot of examples where the pharmacist is jumping in and doing a lot of things, and frankly, the performance is in the outcome measure. So looking at performance measures and how you do this, I really look to the services and then develop a measure around the service.
Yeah, absolutely. And, I think about where we've been through this last year, and a lot of that has been focused on the ultimate outcome, which is improving patients' lives, preventing the risk of illness, and providing, high quality treatments. And that's really been an area where, you're right, pharmacists and pharmacy team members have really led the way toward getting us back to our new normal. So I think, and you look at PQA members make up the largest sector of that population that is helping to get our world back to normal. So certainly appreciate all the work of our PQA members. So one of the questions that came in, Larry, is how do we provide incentives for prescription drug plans that don't have any access to medical data or influence of medical providers? As a matter of policy, it's much more difficult for prescription drug plans.
It most definitely is, and that was one of the things we struggled with Part D is how do you really put MTM with Part D when the pharmacist doesn't have all the information they need necessarily. They're not getting it from the plan, and frankly, the plan isn't incentivized to actually change the level of care within the Part D plan as directly as we would like, and that's why I'm thinking very actively about changing the MTM program now that we have a lot more experience with it. There's a lot more that plans could be doing to improve the health of Medicare Part D beneficiaries. There's a lot more we should be holding them responsible for. And Congress is starting to look at this as you look towards shifting some of these responsibilities to plans. We should be shifting more of the responsibility for their care as well as their cost. And that would include the MTM program and refashioning that in a way that would really force them to be a little bit more accountable for, not so much force, but incentivize them to be more accountable for the health of the Part D beneficiary, not just the spend of the Part D beneficiary.
Well, I do have one final question for you, Larry, and I know this is an area that you're particularly passionate about, so I saved this one for the last because I want you to kind of share a little bit of your thoughts and ideas about this. You know, the future of pharmacy, you described it all throughout last year as we talked about the COVID pandemic and the opportunities, and we've seen that play out. And there were so many opportunities for pharmacists to be able to show their value and show their place on the healthcare team. So, you know, one of the questions that came in was, how do we seek to make those changes more permanent in terms of incorporating pharmacists into the care of a patient for preventive health and point of care? And some of the things that you're really passionate about, monoclonal antibodies, as you mentioned. So give us your thoughts on maybe the policy side of that, but also just the practical side of making these more permanent.
Well, thanks, Mike, for that opportunity. I truly believe that pharmacists are most effective in working with their local communities, with their states, particularly in the Medicaid program. We need to get away from pharmacists just dispensing the drug and being held for things that they can't really control. There's a lot that the pharmacist can do. There's a lot the pharmacist can control. There's a lot the pharmacist can be incentivized to control in the Medicaid program. You know, I think outside the box, and I've heard some of your members talk very passionately about this, one that jumps to me and in terms of a huge opportunity to save money in the Medicaid program is prenatal care. There's a lot that the pharmacist touches. There's a lot that the pharmacist touches to a pregnant woman on Medicaid that is often in the pharmacy, often seeking advice, not knowing exactly where to go. Pharmacists are very well positioned to jump into services that frankly we should start measuring. We should start developing measures, and I know it takes a long time to develop the measures, but you know, to me, it starts with the service. What do you want to be providing? What can you provide? What can you get the data to provide? How do drugs interact with the data that you have, and how do you leverage the position the pharmacist is in the community to make the impact on the beneficiary population that you're looking at? When you look at the Medicaid programs and social determinants of health, I can't think of any provider in the healthcare system that's better positioned than the pharmacist to actually jump in and make a huge difference in terms of cost and quality. And the pharmacist is just incredibly well positioned to do that. But it's going to happen on a state-by-state level. It's going to happen with demonstrations. It's going to happen through CMMI. The other thing that I would do is getting back to something I said earlier, is get someone into CMMI. I mean, the pharmacist community needs someone there to be an advocate. You know, it's just so disappointing to me that we watched a demonstration like Enhanced MTM just get lost in the fact that there wasn't a champion there to really be there when the evaluation happened. To remember back when we started this, what the whole purpose of it was. It wasn't to measure the payment to the plan. It was to measure the value of the intervention of the pharmacist. And I think you've got members, you've got people even on the agenda here today who are going to talk about some of that effectiveness that happened through the Enhanced MTM program. Companies were born out of that. Pharmacists have a role, and pharmacists should be pursuing the roles. Don't give up on some of these things that have failed you. I would take the learnings, take the data from some of these demonstrations, dig into that data, insist that CMS release it to show you what those interventions actually yielded. Because I think you'll be surprised. I think you'll be surprised of the value that was there, and I think you'll be surprised at how much value was there.
Well, an incredible amount of insight and food for thought and a lot of opportunities for the future, Larry. Certainly appreciate all of your thoughts on kind of the future for medication use quality. Appreciate Mark joining us. Thanks so much for your time. And we're now going to take a short break of about 2 minutes, and then we'll come back on set and begin the town hall.
Thank you, Micah. And thank you all, PQA.
welcome back. I want to continue this town hall with some additional reflections on my vision for PQA's future. It's my honor and pleasure to address you as the Chief Executive Officer for the Pharmacy Quality Alliance. Tomorrow officially marks the culmination of my first 100 days in office, and what a swift transition it has been. I'm excited to share with you that PQA is a strong and vibrant organization teeming with opportunities for the future. PQA members are the lifeline to achieving our mission, and your engagement and participation is vital in informing, leading, and operationalizing the work of PQA. This past year has been a challenge for us all, but thanks to the selfless sacrifice of our PQA member organizations, there is a light at the end of the tunnel. At this time last year, our world was focused on controlling the spread of COVID-19. Over this past year, we've witnessed the development of new treatments, tests, and vaccines produced in record time, instilling a sense of hope and promise to people across the world. Pharmacists and pharmacy team members have also stepped up to provide vaccinations and point-of-care testing services to patients across the country. Those efforts were led by our PQA members, and we are grateful for everything you all have done and continue to do to bring closure to a very difficult chapter in our world's history. The worldwide pandemic also exposed several vulnerabilities in our healthcare system and gaps in patient access to care. And there is much work to be done going forward to optimize medication use quality in this new normal. One of the most important efforts PQA is leading is the development and implementation of pharmacy measures which give pharmacists an opportunity to demonstrate their contributions to value-based care. This effort directly aligns with PQA's original aim of achieving a pharmacy business model that reports real value delivered rather than just the volume of prescriptions dispensed, thus supporting our healthcare system's transition to pay for performance. PQA's growing research effort and long-standing commitment to quality measure stewardship perfectly align us to carry forward this vision in partnership with you. Achieving outcomes-focused pharmacy measures will be an incredibly heavy lift, but we will accomplish this with the active participation of every one of our PQA members, all while ensuring that the voice of patients, the ultimate beneficiaries of our work, are at the table. By serving as the measure steward to complement these new and innovative value-based models for care delivery, focused on improving medication use and services, PQA will assert its role as the definitive voice and source for medication use which improves quality, value, and patient outcomes. However, measure stewardship is only one piece of this complex medication use puzzle. Mapping out the complete patient medication journey from ideation to implementation requires a comprehensive and multimodal approach centered around data. PQA must continue to focus on strategies to utilize data to show the importance of prioritizing medication use quality. Prescription claims will remain a core component in the evaluation of quality and value, but we have a unique opportunity going forward to use data to paint a more complete picture of the patient's medication experience. The emergence of novel electronic care delivery platforms and patient care documentation systems present an opportunity for pharmacists to demonstrate their important roles in team-based care in our healthcare system. This provides opportunities to meet patients' needs and to close gaps in care. Adherence remains central to measuring the quality of medication use. Capturing additional data can reveal new pathways to improving medication safety, appropriate use, and outcomes. This is particularly true in relation to ensuring health equity and addressing social determinants of health. These important public health issues are and will remain strategic priorities for PQA. Establishing pharmacy performance measures and leveraging new data are important steps toward improving medication use quality. But these efforts only make sense when they're translated into real and measurable value. Value is much more than just quality over cost. Value is optimized patient health outcomes. Value is realized at the individual and population levels. Value incentivizes and rewards best practices. Value drives innovation and delivers better care models. Value exists in the absence of harm. Value is the ultimate end game in healthcare, the most impactful of team sports. The primary challenge to defining value is the variation in definition depending on which sector or organization you represent. With that in mind, PQA's unique membership composition and consensus-based process empowers our members to collectively lead our healthcare system's pursuit of real and measurable improvements in medication-related value, thereby moving our healthcare system into a new space where the value proposition for medication use is harmonized across all sectors and organizations and delivers better outcomes for patients. Over these past 3 months, I've had the pleasure of connecting with many of you on a deeper level, and I'm looking forward to continuing those efforts in the coming months and years. Since joining PQA, I've confirmed 2 of my primary assumptions about this organization. The first is that PQA is a truly special organization, boasting a strong and visionary board of directors and arguably the most broad, diverse, and passionate membership base aligned through the single aim of optimizing medication use quality. The second is that PQA team is supporting me in this role is an incredible group of talented and skilled professionals who work tirelessly every day to fulfill our mission. Following the footsteps of a legend is not easy. The path that Laura Cranston laid out in 2006 with the launch of PQA was bold and uncertain. Thanks to her leadership, PQA has measurably improved medication quality for millions of patients over the past 15 years, and I'm grateful for her service and dedication. Just as Laura paved the way, I'm excited to blaze new trails alongside each of you to transform our shared passion for improving medication use into action in addressing the quadruple aim of healthcare transformation. Thank you for the opportunity to serve as your Chief Executive Officer, and I look forward to working together with each of you in the days ahead to lead this organization into its next chapter and to make measurable impact on patient care and medication use. So the first question that came in is, data seems to be key in measuring pharmacists' contribution to healthcare environments. So what are your thoughts on the use of data and where we're headed in the future? And so I think we have to look at data as a constantly changing thing. There's a lot of opportunities within the prescription claim environment. And so we know that prescription claims are going to be a huge component of quality measures going forward. But what we have to identify are where are those opportunities to collect data outside of just prescription claims. Whenever you look at all of the new data systems that are being implemented, how do we connect those data systems up, not just within the pharmacy community, but how do we link up to other environments? I think a great example of that is actually how we've addressed COVID vaccinations. So you look at all of these different pieces of data that tell a more complete picture. And I think that complete picture is something that we have to present as we go along as kind of a changing process to share with health plans, and they've got to connect to other medical providers and really close the loop on gaps in care. So I think the immunization example that we've had with COVID-19 vaccines, I think it's a really great opportunity for us to learn from what's being connected and what's not being connected. Because there's a huge gap, I think, in that communication carrying across all communication sectors. So what are the PQA's highest priorities for the rest of 2021? As I came in and as I've learned a lot about PQA, we really have a strategic plan goal by the end of 2021 to realize a lot more of the immunization work that we've started. And so immunizations is a huge component of where we want to focus during 2021. We want to really leverage the information, as I mentioned, with not just COVID, but there's a lot of opportunities around influenza. There's a lot of opportunities around pneumococcal vaccines. There's a lot of opportunities to capture that more complete picture. And so I would say that immunizations and building pharmacy performance measures that focus on immunizations is one of our key priorities for 2021 to close out. Social determinants of health, that's something that our board of directors is very passionate about, and I know many of you as our PQA members are very passionate about. As we've had our conversations over the past couple of months, we know that organizations are focusing very, very intently on addressing health equity. And that is another one of our key strategies at PQA and our strategic priorities. specifically looking at how do we close those gaps in health equity, and how do we leverage the conversations that we know that are being had at the pharmacy counter. How do we look at those opportunities and those conversations that need to be captured and communicated back? So how can we better inform our healthcare system, the entire provider community, and ultimately, how can we close those gaps for patients, whether it's specific to medication adherence or it's something that's externally related to medication adherence but has an effect on medication adherence. I think that's a great opportunity for us to help close some of those gaps. So, one of the other questions that came in is what is the timeline for pharmacy performance measures that PQA is working on? So I think this is a great example of the value of PQA and how we develop measures. I've heard external entities talk about the intent of PQA measures and the thoughtfulness of how we develop performance measures and what that looks like. I think a great example of that work is our Community Pharmacy Foundation grant that we're working on in partnership with CPF, specifically looking at pharmacy performance measures that may be more speaking to what Larry and Mark just talked about. And those measures are specifically looking at services. So you're looking at specific measures that look at how A1Cs. They look at not just capturing the A1C, but also showing improvement in the A1C. You also look at blood pressure, and we're trying to close those gaps in blood pressure. It really blows my mind that we've had all of these years and all of this focus on improving diabetes and blood pressure, and I think there's been some missing links, and a lot of those missing links and missing conversations probably need to be brought into the discussion, and that's, I think, where pharmacists can play a huge role is really trying to work to close some of those gaps. So we're building performance measures focused on A1Cs and blood pressure and even chronic lung disease. You look at those opportunities, those are endless. I think the specialty pharmacy space is one that we see that there's a huge opportunity. And we know that specialty pharmacy is a growing drug driver, both in terms of innovations, but also expense. And so we have to figure out a way to handle some of the specialty pharmacy marketplace that's out there. So I think specialty pharmacy is another focus that we want to kind of address further. SDOH is one of those pieces of work that I'm really excited about in terms of where PQA is going. That's one of the feasibility concept measures that we're looking at, is addressing SDOH, but also providing SDOH survey opportunities that are meaningful, that can be communicated back to value for not just pharmacists, but patients and health plans and providers as well. So using the access points that we have to really leverage and maximize those opportunities. So one of the other questions that came in is, how can PQA best support the transition to healthcare's new normal after COVID-19? You know, I always think about that terminology, new normal, and what that means, but the truth be told, I think the new normal is a new frontier. I think there's an opportunity for us all as we talk about the flexibilities and challenges and things that we've seen over the past year. The question is, which one of those are going to stick? And which one of those are best practices that maybe need to be a new normal going forward? And so I think the learning is really on us as healthcare and the healthcare provider community, but the healthcare plan community, the healthcare systems themselves. The learning is on us. What we do with that is going to be the difference between whether we improve our healthcare system or we continue down the previous path. But I think that new normal, we have to really accept that the new normal is really a new frontier. And there's a lot of opportunities for us to perfect a system that probably needed some changes. So I think we've seen a lot of that. But I think at the core of all of that, whenever you talk about what measurement means and how PQA can play a role, it's that value proposition and making sure that what we're doing actually produces improved value. If it doesn't improve value, then we will have a much harder time standing it up. But there's a lot of things that we've seen that improve value, and those opportunities really come to fruition, and we've seen them play out, and really has led our country down a positive path. So one of the other questions that came in is, Where's the low-hanging fruit on measurement opportunities for pharmacists? The ability to capture consistent data on care being provided now. So low-hanging fruit, I think as you look at the increased roles that pharmacy as an entire profession has played in this, I think you would identify immunizations and point-of-care testing services. I would say those are probably the lowest hanging fruit because we've seen those roll out through the COVID-19 pandemic as standards and expectations in pharmacies. And so if I were talking about low-hanging fruit, those are top of mind at this point. I think as you look at more opportunities in the future, you can really focus on other targeted disease states. We have several pilots going on right now, and those pilots are focusing on pharmacists in diabetes management, pharmacists in blood pressure management. We've seen pharmacists play a greater role in remote blood pressure management over the past year as we have seen, provider offices really grapple with some state regulations and some requirements of not being able to see patients and patients not going to see their physicians and other medical providers. I think it's created a challenge, but an opportunity, I think, for pharmacists to work alongside our physicians, our nurses, all of the other providers that are caring for patients to really supplement those services. And I think telehealth, Mark McClellan just mentioned this earlier, I think telehealth is a huge opportunity for the future, and I think there's a role for pharmacy to play in that whole process. So one of the other questions that came in, and I think this is one that, just truth be told, that I had to learn a lot about really quick, and that was the move toward digital measures. We do know that CMS has a directive that by 2025, measures will be digitized, and that's a priority for us. We know that as we have kind of ideated this, we originally had a target of 2030, but we actually do have a plan now to try to move toward digitizing our measures by 2025. I think there's a lot of challenges in that space. I have a lot of learning, honestly, from our performance measurement team. They are the experts in measurement, and so I know just enough to be dangerous as far as digitized measures and what that looks like, but I'm very thankful that our team has brought me up to speed on that, and I do think there's an opportunity for us to really change some of the technological pieces of what we described in data with the bringing the measures into 2025 digitized measures. So I think there's some opportunity there. So one of the other questions that came in is, will pharmacy performance measures help to support and inform provider status for a pharmacist? I think anytime in my previous role, anytime I would go in and I would talk with our health plan members, whenever I would talk about the value of pharmacists and the importance of pharmacists on the healthcare team, one of the things that I always heard was, show us the value proposition, show us the opportunity, show us where it improves care. And so I think we have a unique opportunity with these pharmacy performance measures to actively build that out, to build out a value proposition that actually improves care for patients, but also promotes value back to health plans, ultimate payers. Ultimately, they control a significant portion of kind of the management of patients. And I think it's really important that we engage with health plans and make sure that these value-based measures are measures that health plans will want. Because there's a challenge in producing a measure. If a health plan's not interested in it, then the measure essentially lays dormant. And so we've got to make sure that we align. The beauty of PQA and the beauty of this organization as a whole is the fact that we have so many engaged health plans, pharmacy benefit managers, community pharmacies, associations, academicians, life sciences companies. Everyone's a part of this organization that is really focused on value-based care. So I think there's some huge opportunities in this space to really innovate. But the only way we can innovate in any of these propositions is to make sure that everybody's aligned that this is the direction we need to go in. Because if we don't go in the right direction and uptake is low on this, then we haven't achieved our goal of improving value. You know, to that end, the question came in as PQA has traditionally been a big tent in terms of our approach to membership. That's plans, PBMs, pharmacies, academics, vendors, and others. How can we make the big tent even bigger? And are there groups PQA seeks to add to the table in the future? Well, I think there's a lot of opportunity. I think we always grow within the family. But you always want your family to grow as well. So I think there's an opportunity here for us to engage. And I think there's a unique opportunity in the technology space. I think as we mentioned a little bit with electronic data systems and what that looks like and kind of the emergence of things like e-care plans, that we see additional data that's not claims related that's being collected. I think there's an opportunity to bring those folks in to have more engagement from those areas. But I would say that, you know, the Big Ten approach at PQA was one of the things that brought me to PQA. It's one of the things that attracted me to joining this great organization and each of you. And so I see there's a great foundation laid, and the foundation will only continue to build as we continue to build out some of these ideals. How will you advocate for the value of medication use quality beyond PQA's membership and to the broader healthcare system? I think that's all in terms of messaging, how we carry this message forward. Advocating within PQA's membership, I don't have to tell each of you because you've joined us today. I don't have to tell you the value of pharmacy, the value of pharmacists, the value of quality in this space. I don't have to advocate to you all because you all are here. You understand it. From my perspective, I think it's making sure that we have a seat at the table. It's always been impressed upon me that if you're not at the table, you're on the menu, right? So I think there's an opportunity for us to just make sure that we're at the table and we're having these conversations, making sure that everyone is aware of the value of medication use in the overall healthcare system and what that means for quality. And so for me, it's always ensuring that you have a seat at the table. And so that's been my mindset, and that's the mindset I'll carry forward at PQA. Okay, so one of the questions that came in is, last week you announced some staff changes, including the creation of a new position for Lisa Hines focused on quality and innovation. What are your innovation goals for PQA? You know, I think whenever you come in and you get an opportunity to look at the staff, I really came in with a fresh set of eyes. I came in from another organization in another state that was a nonprofit, but definitely had a different focus than PQA's. And so as I came in, I really spent several months looking at our structure, having one-on-one conversations and dialogues with each member of the PQA team. And it really confirmed for me that we had the right people on the team. And so as we look at these changes and these opportunities, it's really aligning that team to make sure that we're positioned well going forward to not only be thriving and to grow, but most importantly, to provide support to the people that come to us to want to focus on medication use quality and improving that. And so I spent a lot of time looking at our organizational structure and how it would position us best. And so specific to quality and innovation, these are two things that kind of go alongside of each other. We have a great research team, and the research team works very closely with the performance measurement team. And so it seemed natural to bring those two teams together to allow research to inform measurement and vice versa. And so with the vision that I had for that role on quality and innovation, it's really bringing those two teams together to really strengthen both of their efforts and to really focus on how we can carry that message forward from ideation all the way to implementation. And so for me, it seemed like a natural fit. And we've got great teams and great individuals working at PQA. So that's really what I had focused for that specific role. So, you know, I think one of the other questions that came up is kind of what does this future look like for PQA? In my mind, where we get to 5, 10, 15 down the years down the road is that we have a system that has a performance measurement system that shows the value of pharmacists and the value of pharmacy and the importance of medication use as we go through the process. And it's a fully integrated, fully enveloped team that's communicating across all systems. And so our documentation systems are fully integrated, they're bidirectional, they're communicating back and forth, and they're communicating that value proposition. And ultimately, at the end of the day, our plans and payers translate that value and see that value and implement that care because they know that it improves the beneficiary's health and ultimately informs up to the ultimate payers that are there. So in my mind, it takes all of us to get to that place, but it's really just the first thing is we've got to build the field of dreams, and then the second thing is we've got to really flesh that out through what data we have to close some of those gaps. And then the third thing I think is the most important is we have to translate that into value, and it has to have a value proposition that means something to everybody coming to the table, including our patients. So with that, I'd like to turn it back over to Lauren Kirk. This has been a pleasure. Thank you for your questions. And Lauren, take it away.
Absolutely. Thank you, Micah. All right, what a wonderful way to kick off the 2021 PQA Annual Meeting. Thank you, Micah, for sharing your vision there. It's been a great kickoff, and I look forward to engaging everyone this week. The entire PQA staff looks forward to that. And so it's now time for the PQA Innovation Theaters, and you can access those individually through the All Sessions tab. And after that, you'll be able to join the open forum on pharmacy level measures concepts to support value-based arrangements. And then, of course, don't forget, we'll be able to test your trivia knowledge to cap off day one of the meeting here. So thanks again for being part of the PQA Annual Meeting and part of the PQA family. We look forward to having you all week here for the 2021 PQA Annual Meeting.